Hey, hello, everyone. And thank you for joining us today for our research webinar series. My name is Shaista Malik. I'm the UCI Associate Vice Chancellor for Integrative Health and the Executive Director of the Susan Samueli Integrative Health Institute. Before we start, I want to review a few Zoom housekeeping items. We are recording this session. After the session, we will post this webinar on our YouTube channel. Everyone will remain on mute to limit distractions, but please feel free to communicate with us by taking advantage of the chat feature on the bottom of your screen. And then please direct any questions for the panelists in the Q&A feature. We'll be moderating a Q&A session after both panelists present. So the Samueli Institute is committed to research, education, and clinical care. Our research addresses our growing health challenges while adding to the evidence base for integrative health practices. With a history of awards from national funding agencies and private foundations, our multidisciplinary researchers are dedicated to exploring the science of illness versus wellness, publishing and sharing findings, and improving lives. So we bring this series to you in an effort to share the current research we support across our UCI campus with our extremely talented researchers through our pilot study programs and our Samueli Scholars program, which award funding to the most meritorious of our faculty who are doing research related to or directly in integrative health. So for more information, you are welcome to visit our website, scihi.uci.edu. And so with that, it's my absolute pleasure to introduce our first speaker today, Dr. Kalpna Gupta. Dr. Gupta is a professor of medicine and a Samueli Scholar of the Susan Samueli Integrative Health Institute. She initiated the pioneering work on mechanisms of pain in sickle cell disease and mitogenic signaling of opioids. Her bench to bedside and collaborative multidisciplinary research has identified several mechanism-based integrative approaches, including diet, companionship, acupuncture, and perception to relieve pain. She is not only a well-known scholar nationally, but she's also involved in advancing careers of trainees and as a recipient of the NIH's Excellence in Hemoglobinopathies Research Award, and has served as an advisor to NHLBI and serves on the Diversity and Equity Initiative of the American Society of Hematology. Please join me in welcoming Dr. Kalpna Gupta.
Thank you very much, Dr. Malik. It's an absolute honor to be speaking at such a prestigious and very engaged institution, which is trying to reduce the agony of people suffering with multiple conditions, including pain. And thank you for that very warm introduction. With that, I would like to start my presentation and talk about the passion of my life, which is studying pain in sickle cell disease, but not only in sickle. I have also been engaged in cancer pain and other opioid effects. So today I am going to talk to you briefly about integrative pain and novel targets of pain, some of which have been actually recognized by my laboratory. So before I start, my slide is not moving, Camber. Okay, it's moving now. These are my disclosures with some industry funding and consultations. Now, what is pain? We all feel pain at times, but this is best depicted by this very talented artist who had sickle cell disease all his life, Hertz Nazaire. He called it 10 redefined. What the pain of sickle cell disease feels like for me, I wish to inspire empathy, and compassion in others so that we may someday end the suffering of the sickle cell community worldwide. And I would say our efforts should be to end the suffering with pain worldwide. With that effort, we would like to now focus on first, pain in sickle cell disease. Why focus on pain in sickle cell disease? Primarily because it afflicts individuals of African and Latin American descent in the United States, while globally, it really afflicts people who are underserved and in resource-limited settings in countries like India, which also has a large burden of it. The worst part is that the pain can start during in infancy and may continue to increase throughout life. About more than 50% individuals with sickle cell disease report chronic pain at any time in their life. They have increased sensitivity to touch, which is mechanical hyperalgesia. They feel like piercing, throbbing, stabbing of pins and needles, increased sensitivity to cold and heat, which can you imagine not being comfortable in a warm room, not being comfortable in a cold climate. And the pain, another kind, which is acute pain, is unpredictable, and recurrent episodes can occur due to the blockade of the blood vessels, which is called vaso-occlusive crises or just crises. And this leads to hospitalization and reduced survival. And Hertz-Nazer is just one example. We lost him, and he was just suffering with unimaginable pain throughout his life. What is the answer? We know opioids have been used for centuries, not decades. Are they a problem or panacea? We had known the side effects like sedation, dizziness, pruritus, constipation for a long time, and we have been trying to defeat those with some novel targeted drugs that have been developed. But tolerance, hyperalgesia, addiction, they continue. And most of all, in the last few years, opioid deaths have really gripped the nation with grief. In California, in the last 1 year, if anything, the opioid deaths have risen significantly. Is cannabis the solution or a problem? 89% of patients had a 50% reduction in depression after 20 minutes of cannabis use. But did it relieve the problem? No. The baseline symptoms of depression gradually worsened over time in this population. Therefore, this short-term approach is not going to work. So how did we approach the issue of resolving pain, reducing it, treating it, preventing it? So the first is, in my strategy, prevent pain at its source from being evoked. Therefore, we have to target the disease process that evokes the nervous system to transmit pain. And these strategies would be called disease-modifying strategies, and these have to be disease-specific. And this is one of the major issues with pain research, that we are always trying to develop an analgesic in vacuum. We are not trying to think of the primary condition that evokes it, because we are actually comparing apples to oranges. The diabetic pain, the sickle cell disease pain, and the cancer pain, they have some differences. They are not going to be one size fits all. And therefore, understanding the disease process is important, and targeting it where it emerges at the initiation. The second option we have is to treat pain once it is evoked. And that would entail targeting the nervous system or the nociceptive mechanisms. And for this, we would have analgesics, as we call them. Opioids, we know well about them. NSAIDs, but they perturb the stomach. And in patients who are receiving multiple drugs, adding more opioids and NSAIDs can only harm them. So the integrative approaches come to mind, and they can be effective, and they can be used in combination with other things. And that's where we are also focusing a great deal. And the third is perception modulation, which has not been utilized much. The mechanisms remain very under-examined. And this is where we target the brain and use brain as the markets, as the master orchestra to control downstream through the spinothalamic system and control the pain from the brain and also control some peripheral effects. And this can utilize more integrative approaches like mind-body, CBT, hypnosis, virtual reality, environment, etc. So with that in mind, we started asking, how can we prevent pain at its source from being evoked? And then the question comes up, how is it evoked? And as I said earlier, pain is a major comorbidity of sickle cell disease, leading to hospitalization and reduced survival. Reduced survival. Some people live into their teens. Some children don't see their 5th birthday. So this is an important condition, and this is an important symptom to deal with. And what is it? What is sickle cell disease? So normally we have donut-shaped red blood cells, as you see here, and they can roll like the tires of a wheel. But under low oxygen, what happens is they become sickle-shaped, they shrink. And when they are this, they cannot roll anymore. It's like not only a flattened tire, but a half tire. And what happens then? The blood supply to different organs, that is the function of the blood to bring red blood cells, to bring oxygen and to bring food to different parts of the body. And that stops. And also they block the blood vessels because they cannot move. Together, this causes the worst kind of pain known to mankind. And they have to be hospitalized, and sometimes they don't survive this pain. And therefore, the question was, what is the mechanism of this pain in sickle cell disease? Now, the central nervous system in itself is a very complicated system. It has two components, peripheral and central. In the peripheral, we have all the organs other than the brain, and skin is has a very large repertoire of nerve fibers, and it transmits them to another peripheral organ, which is called the dorsal root ganglion. Now, what is dorsal root ganglion? It houses the body of these nerve fibers, which we see in the periphery. So the body is like an octopus, which has two tentacles. One goes into the periphery and the other goes to the spinal cord. And the purpose is that the signals or nociceptive stimuli, like if somebody hits me, I will feel pain. So that is a nociceptive stimuli. But it doesn't have to be an injury. It could be internal, endogenous, like increase in inflammation, oxidative stress, or injury to the nerve fibers. When that happens, the action potentials are generated and they are transmitted via this red arrow to the body of the neuron, which gets activated, and it amplifies the signals and send them through this red arrow to the spinal cord. In the spinal cord, these signals are further amplified. They synapse with the fibers coming out from the brain, and then they send these amplified signals to the brain. And here a lot of things occur in the spinal cord. It's also called the gate, where there are glial cells. They get activated when this happens, and they start throwing out all kinds of inflammatory substances. And they use different receptors like TLR4, reactive oxygen species are generated, neuropeptides like substance P are generated, and all this actually creates a demon, and that then transmits all these signals to the brain. The brain has the power to override this actually. And what brain can do is two things. One is make the person feel the pain or override these signals and send a set of signals through the neuromodulation to the spinal cord and tell them to stop. Now, this system, we all know a lot about how disease causes pain, sends the signals to the brain. Now, we have not really exploited much of this system, and brain can be modulated more easily actually through perception, through the environment. And what is the environment in a chronic disease? In a chronic disease which occurs in low resource settings, stigma, where a person requires opioids all the time, the stigma of even going to the clinic, limited resources, psychosocial factors, feeling isolated, all these add to it. So when the signals are coming from here and then the signals which are negative are coming from here, the pain is amplified. Whereas if we improve these signals coming from here, we can have the brain override these adverse signals. So what I will do today is I will give you two research pieces from my lab where I will show you how this peripheral system and the central system work in sickle cell disease and what strategies can we use to target them to relieve or to reduce or to prevent pain. And in sickle cell disease, to start with the peripheral system, there is crisis, as I explained. What it causes is hypoxia, ischemia, reperfusion injury, inflammation, hemolysis, organ damage. Each of these individually are capable of causing damage and being noxious to the central nervous system, promoting nociception. Over the years, my laboratory and some others have created a huge list of different noxious stimuli, particularly hemolysis, where cell-free heme is released, which is unique to sickle cell disease as compared to diabetes or cancer. And they can go and activate this system. Now, what we have done in the past few years is try to use the environment. This is an easier thing to do. There's no clinic to go to sometimes, and these can be easily modulated. So let me show you what is the environment and how can it influence pain. Diet, nutrition, company, that is companionship, isolation, loneliness, stigma, sleep, pleasure, trauma, depression, anxiety, food supplements. All these are our negative or positive environment. And there were studies in sickle cell disease for the last many years from Atlanta, from Sudan, from India, where they showed that some food supplements like fish oil or omega-3 fatty acids or coenzyme Q10 all were capable of either reducing oxidative stress and inflammation and reducing the incidence of VOCs in people with sickle cell disease. However, when these studies were replicated in a larger double-blind cohort by Matt Khine, they did not hold true, particularly for omega-3 fatty acids. Now, we wondered, what is the truth? Is it the variability? Is it the small n? Is it what else people were having? So what we did was to answer this question and prove or find an answer, can we modulate pain with environmental modulation? Say, in mice, it is a little difficult to do, but these mice are very special that you see here. They express sickle cell human hemoglobin completely. They do not have any mouse hemoglobin. So they also show the features of pain, hematological and pathological, which are observed in patients with sickle cell disease. And importantly, our lab found that they develop chronic mechanical, thermal, and musculoskeletal hyperalgesia, which are the characteristic features of pain in persons with sickle cell disease. So to examine this, what we did was we divided the diet into two kinds. One is the regular rodent diet, which mice get in the laboratories. And then we formulated it further and we called it the sickle diet. And what we did to this, not we, but somebody else did it, is they added more minerals, more amino acids, more vitamins. And what we did was we added omega-3 fatty acid to it. And we also increased the energy density with protein and fat. Why did we increase the energy density? Because in sickle cell disease, the metabolic requirements are very high because increased hematopoiesis, because of organ damage, so they require more energy. And then what we did, we prepared several groups of mice in which we gave either the rodent diet, as we call it RD, and we kept them with or without a mate. So we had a male and we had him alone without any other mouse in it. And we called it a deprived group. So this represented isolation and poor living conditions because of poor diet. Then we had a happy group of mice where we had the male mice with a female companion, and we also gave them the enriched sickle diet SD. And then we had an unhappy group where the mice were living happily in companionship with sickle diet, and we withdrew both of them and left the male alone. This represents trauma, that if somebody hears a bad news and they have pain, it goes up. And we all know this, and we might have experienced it. So let's see what happens in these groups. So the mice that were deprived, they never had a companion and were on regular diet, their serotonin levels in the brain were very low and their pain was high. When we had the group which was happy, where they had a male had a female companion and was on a sickle diet, the pain went down. But when we withdrew the female and we withdrew the rich diet and replaced it with the poor diet, the pain goes up and serotonin levels go down. So here is what is serotonin and what is dopamine. So these are the mechanisms I was talking about, how perception can really cause neuromodulation at the level of the brain, and the brain can override the signals of pain coming through the spinal cord. So in the brain, there are different regions which are capable of releasing these happy compounds, dopamine, norepinephrine, serotonin. And what happens is these are released in different regions of the brain. And as you can see here, they trickle down into the spinal cord. And that's where they can get into that gate and modulate the signals that are generating pain in the spinal cord. And what happens is that there are synaptosomes which actually make contact with each other. And the serotonin then binds to the receptor and then actually activates the spinothalamic pathway. And there are drugs which have been developed to increase the levels of serotonin and norepinephrine, which is called duloxetine. And actually it was developed for anxiety, depression, but it was not successful in that. Instead, it has been effective in reducing pain. But it's not a drug that one would like to use all the time. So what we looked at, that when we gave our mice an environment full of deprivation or unhappiness and pleasure, what happened to their serotonin and dopamine levels in the brain and in the spinal cord? So what we found that the deprived mice who had more pain had lower levels of serotonin, the happier mice had higher, and not surprisingly, when the happy environment was removed and they were made unhappy, the serotonin and dopamine levels go down. And this happens in both the brain regions and the spinal cord. And just to show you what it looks like on the brain images, this is the RVM where serotonin is released, and you can see serotonin is released in a happy mouse. And in withdrawal conditions, the serotonin levels go completely down. Now, this convinced us that this happens in the brain. But what I didn't explain fully was that brain will send the signals to the spinal cord, but then spinal cord not only would modify the brain for the pain, but it will also send signals to the periphery, to the skin and other organs, where the inflammatory and other signals can be other outcomes can be modified. So in these mice, what we found was when the female mice were withdrawn and the sickle diet was withdrawn from the cohort, their white blood cell counts went up. This is a peripheral phenomena, which means that this effect was not only central, but also had a peripheral impact. Whether it was modulated by the central nervous system or it was an independent effect, that still needs to be determined. But the good news is that with this modulation, we can see that we are increasing the disease process when we are depriving people of their happiness and their companionship. And isolation and poor food is increasing their inflammation. And then the spleen in these mice is very big, as you can see, compared to control mice. And the spleen in size increases further, which means there is more hematopoiesis, there is more stress in these mice when we withdraw the happy conditions. So this I already showed you, and this is just to remind you that duloxetine can do this. And we found that duloxetine, when given to these mice, could relieve hyperalgesia. I'm not showing the data today. So how does it translate in terms of human pain? So there are several studies done, and also in mice, we did an additional study to see whether we gave if we gave these mice a suboptimal amount of morphine, which does not reduce pain, can that reduce pain when the mice are in a happy environment? And yes, they did. And this is very similar to what was observed by a group of investigators at Johns Hopkins, that high symptom burden and depression in patients on chronic opioid therapy occurs. And this is responsible because of central sensitization, where the whole system is sensitized. And when they have more cognitive impairment, there is more pain, and vice versa. And then pain and pain-related cognitive and affective variables are associated with daily variation in opioid use in sickle cell disease. Now, all this occurs at the level of brain. And therefore, if we can control the activities in the brain, we can modulate the requirement of opioids. This is one way of preventing opioid addiction and opioid deaths. So with that central effect, I will leave you there, and I will take you to the peripheral impact and the mechanisms. And what we found in many years of our work is that the mast cells are highly activated in these mice. In the skin, they are even present in the parenchyma of the brain. This is an image from a section, a thick 100 micron thick section of the skin of sickle mouse. In the blue, you can see the nerve fibers in 3D. And in the green is the marker Fc epsilon R1 for the mast cells. And red are the tryptase granules, which are released by the mast cells. Now here you can see the mast cells are totally disrupted. It's like a nuclear fission. And it's a process called traps, which are formed by mast cells, something we discovered in our lab, but I won't go into today. But what is important is to notice tryptase. It's a protease. Its job is to chew up the tissues. And look what these mast cells are doing. They're hurting the nerve fibers. These nerve fibers are just strangulated. They are strangulating them in different parts, causing nerve injury. And we had shown this nerve injury in these mice several years ago, so it's published and I'm not showing it today. But what happens with this mast cell activation? Mast cells release tryptase. It acts on the nerve fibers via protease activated receptor 2, co-activates TRPV1, the capsaicin or chili pepper channels. Both together stimulate the nerve fibers to release these pro-nociceptive neuropeptides, calcitonin G-related peptide CGRP or substance P, SP. Both are increased in sickle cell patients and in sickle mice. And these are vasoactive and neuroinflammatory. They act on the vessels, causing vascular dilatation and increasing venular permeability. And then substance P is also active in co-activating the mast cells. So the whole system is on autopilot. And what happens is there is a vicious cycle of mast cell degranulation and nociceptor activation, leading to central sensitization, continuation of pain, even in the absence of a nociceptive stimuli. So how can we circumvent these peripheral and central insults? Can we develop something that can actually be preventive, which would be disease modifying, as well as analgesic? So what happened was we looked at palmitoyl ethanolamide, which can cross the blood-brain barrier. It's also synthesized endogenously in us. But in our mice, we found it was reduced. It is present in egg yolks in very high amount. The way it was discovered was that in Italy, they found that the children, about several thousand children were studied in 1960s, 50s, and they found that the children who had 2 or more egg yolks a day did not develop allergic rhinitis. And then they isolated this compound from the egg yolks. Now we know it acts via multiple pathways. Importantly, it inhibits mast cells. And this discovery was made by one of the Nobel laureates in Italy in 1990s. The second thing is that it increases anandamide, the endogenous cannabinoid or endogenous cannabis within a person by inhibiting the enzyme that degrades it. And using these both at the central level and the peripheral level, we thought it'll be a powerful analgesic and a disease modifying agent. And a very talented postdoc in my lab actually found that the palmitoyl ethanolamide is reduced significantly in the spinal cords of both male and female mice. He then treated the mice with PEA, and he found that mechanical as well as cold hyperalgesia, both were reduced significantly over a period of time by treatment with PEA. We're not the first ones to show that PEA reduces pain. There are many clinical studies and very high doses of it has been used up to 1800 milligrams a day in people, and they have ameliorated hyperalgesia. So with that, I would like to summarize all the integrative approaches to target peripheral and central mechanisms of pain that I have shown you and that I haven't shown you, and the disease modifying effects or their anti-nociceptive effect. We know very well about cannabis, and our lab has done a clinical trial on that. There is diet modification, which can affect both the peripheral as well as the central mechanisms. And then there is CBT, hypnosis, virtual reality, AV relaxation, guided imagery, antidepressants. They all act on the central nervous system and cause psychosocial modulation, can act at the brain level. And then there are many others which can act on both centrally as well as peripherally on the vasculature as well as on these immune cells, ameliorating pain. And I would conclude that nutrition, relationships, emotional stability, and environment to improve well-being can be extremely supportive of reducing pain, preventing pain. And what is even more important from our data that we have shown but not shown today is that maternal health is very important in a chronic condition like sickle cell disease, that early and prenatal dietary interventions can improve sickle cell pathobiology and survival of the pups. Environment, both diet and lifestyle surroundings are important for emotional well-being, and this may be helpful in reducing pain and reducing or preventing opioid requirement. Perception-based interventions are very helpful in this. I showed many. And food supplements, not only PEA, but curcumin we found in these mice can ameliorate pain, CoQ10 in the India study, and many other, as well as acupuncture, can modulate both peripheral and central mechanisms. I would say share the burden, eat healthy. And with that, I would like to thank the members of my team, my many collaborators all over the country, and NIH for their generosity in funding, my institution, UCI, for their support, and University of Minnesota for their support. And thank you very much.
Thank you, Dr. Gupta. That is such a comprehensive picture of not only sickle cell disease pain, but just pain in general. And thank you for painting such a rich picture of the integrative approaches and for sharing your groundbreaking work showing the mechanisms that underlie many of these therapies. So with that, it's my pleasure now to introduce another outstanding UCI faculty member and Dr. Michelle Khine. Dr. Khine is a professor of biomedical engineering, associate dean of undergraduate education, and a Samueli Scholar at UCI. She's the founding director of the Faculty Innovation program at the Samueli School of Engineering and founding director of BioEngine, which is bioengineering, innovation, and entrepreneurship. Prior to joining UCI, she was assistant and founding professor at UC Merced. Dr. Khine received her BS and MS from UC Berkeley in mechanical engineering and her PhD in bioengineering from UC Berkeley and UCSF. She's the scientific founder of 6 startup companies. She's also the recipient of the TR35 award and named one of Forbes' 10 revolutionaries, and by Fast Company magazine listed as one of the 100 most creative people in business. She was awarded the NIH New Innovators Award and was named a finalist in the World Technology Awards for materials, and was named by Marie Claire magazine as Women on Top Scientists. She's also recently named Innovator of the Year in 2017 for the Samueli School of Engineering. And I think I can spend another 10, 15 minutes talking about all her accolades, but she's also a true collaborator and somebody who's led initiatives on mechanisms of pain and therapeutic approaches to pain across UCI and brought many investigators together in that effort. Thank you, Dr. Khine, for joining us today.
Thank you so much, Dr. Malik, for the very warm introduction. And I'd like to thank Dr. Malik and Dr. Gupta for really helping me get into this area of research. This is relatively new for me. My lab I come from a very different background from Dr. Gupta. We're an engineering lab and we've been making sensors for a number of years. And it was really the mentoring of Dr. Malik and Dr. Gupta that I started looking at pain with these sensors. And so before I go, so I want to talk a little bit about the work that we are trying to do in pain, and related to what Dr. Gupta was saying in particular with sickle cell patients. It's this, because pain is currently so subjectively evaluated, there is this spectrum of care that our patients are seeing, because some physicians don't believe that they are actually experiencing the levels of pain that they express. And so, how much opioids do you give? How much do you prescribe? When is appropriate? These are all questions that we're struggling with. And so we thought if there was a better way to quantify pain, that this might help in some of this. And so I'll talk a little bit about the sensors that we've been developing and what we could potentially do with them in terms of pain in general and sickle cell pain in particular. So before I go on, I do want to disclose some potential conflicts of interest with some companies that I helped co-found. And so, as I mentioned, we started getting into looking at continuous physiological monitoring over the past few years. This really was, the inspiration for this was when my son Max was born 4 years ago. He suffered from a collapsed lung. He was turning blue after he was delivered, and I was, trying to convince the nurses that he was blue and he wasn't breathing and something wasn't right, but they assured me, no, he was just sleepy. And finally, I found a very experienced nurse who believed me, put a pulse ox on him immediately, and then immediately rushed him to the NICU, where they discovered that he had a collapsed lung. And so we were in the NICU for 8 days, watching the monitors. They said we could not pick him up or carry him until his lung had healed. And they told us that, that eventually as his lung healed, that the signals would start looking better. And it was during this process that we discovered that all of the monitors that he was hooked up to with all of these numerous sensors could not monitor something as vital, as fundamental as breathing. So you could get respiratory rate, but you could not get volume information out of the monitors that he was on. And so this was frustrating to me, but it really got us into figuring out if we could use our sensors to develop continuous physiological sensors. And so with the help of Dan Cooper, who's our pediatric pulmonologist here at UC Irvine, we developed some sensors technology in our lab into being a respiratory sensor. So we've been developing these very soft Band-Aid-like sensors in our lab, which have a very high signal to noise ratio and a very fast dynamic range. So if you pull on it, you can see the signal, and this is unfiltered signal, right? So this is a very large signal to noise ratio, especially for a soft sensor. So unlike traditional strain gauges that you put on buildings, on bridges that stretch by 1 to 3%, but have a very large signal to noise ratio, we can have a very large signal to noise ratio, but we can also deform our sensors a great deal, which is perfect for the human body. So we started putting these into medical grade polymers and putting them on the body. And we thought if we put one on the rib cage and one on the abdomen, that we could potentially not only get respiratory rate, which was pretty easy to get from these sensors, but also volume information, so flow information, which you typically need a large spirometer to be able to measure. And so we calculated this out. We calibrated it to a spirometer, and then we calculated out our standard error of estimation, as well as our R-squared values compared to our model when we used both a sensor on the rib cage as well as the abdomen. And you can see that the R-squared values fit very nicely, very linear fit to volume measurements from the spirometer. And what's interesting is so the combined model, when we used both sensors, was really, really good. But even when we just used one sensor, we were getting a lot of information about a person's respiration, and the errors were still very low, even with just one sensor. And so this really cemented my my motivation to end system-based reactionary medicine, because we know that physiological changes precede clinical exacerbation. And so if we can monitor these subtle changes in physiological changes in the body, then we could potentially prevent, for example, these very painful VOC events from happening. And so analogous to our respiration sensor, we decided we were going to develop a continuous blood pressure sensor. And so all of us are familiar with the traditional blood pressure sensor, the cuff measurement, where you get one systolic measurement and one diastolic measurement corresponding to when your heart is beating and relaxing for your waveform. But what is less known is that your blood pressure is not a static measurement. You don't get just one value, but it's moving continuously. And so taking a snapshot blood pressure measurement is like watching a basketball game and trying to decide if this free throw at the playoffs is going to go in. And he was the MVP that year. It is the Milwaukee Bucks. Is this going to go in? From a picture, you can't really say until you watch the whole video and you see that it was a complete airball. And so this is what your blood pressure measurements actually look like beat to beat. And you can see that there are huge variations with every beat. And it turns out that that variation is more indicative of cardiovascular health than an absolute blood pressure cutoff value. And so the gold standard to measuring continuous beat to beat blood pressure measurements is the arterial line, where you actually have to insert a catheter in. But this has various complications, including infection, can lead to sepsis. And so in the operating room, as well as in the ICU, it's only used in a fraction of the most severe cases of patients. And so typically about 20% of ICU patients and 30% of OR patients actually have the arterial line put in. The rest of the patients just get measured with a cuff measurement every 3 to 5 minutes. And so if you think about this, the current blood pressure monitors have not changed very much in terms of form factor or output since it was first invented in 1881. And even though we know that beat-to-beat blood pressure variability is prognostic of cardiovascular morbidity, as well as a host of other diseases that we are now discovering, even linked to Alzheimer's disease, very little is actually taken in terms of these measurements. And so we could develop a sensor that was like a little inexpensive Band-Aid that can give you accurate measurements, arterial line information. Then we think that we can actually create machine learning algorithms to be able to predict, various catastrophic events before they occur. And so we published this paper in 2019 where we took our little pressure sensor. So this is similar to the piezoresistive sensor that I showed you previously. But it's a capacitive phase sensor. So there's two of these sensors with a little dielectric in between. I'm sorry, chat. Oh, I got a 5-minute warning here. Okay, I'm going to go a little bit faster here. I'm going to get to how we're using these sensors. So we calibrated these sensors. We've been using them in the operating room as well as the ICU. And our latest papers, so we did head-to-head comparisons. We published this. But our latest paper that just got accepted last week showed that with this algorithm that we developed, we can actually sustain calibrations in the operating room for about 20 minutes, which is pretty remarkable because the other non-invasive approaches have to recalibrate every 60 to 90 seconds. And so we can hold our calibration and we can remove drift. We also used our same algorithm to calibrate PPG sensor data as well, and this also holds up. So we can actually remove drift from wearable sensors with this new intrabeat biomarker that we're calling. And so we've been able to eliminate motion artifacts with these sensors. And so we think that now we're really ready to start using these on a more diverse set of patients. We've also increased the sensitivity of our sensors. We've developed sensors where you don't actually have to align it perfectly over the radial artery. We've also made them significantly more sensitive than when we first published on them. And so you can see this kind of new sensitivity compared to their old sensitivity. And so comparing our sensor to other sensors in the field, so this is our red line. So over a very large pressure range, we can still sustain our very high sensitivity. And so what this means is that we can misalign it to the pulse wherever you feel a pulse. We can misalign it upwards of 4 millimeters and still have a very robust signal. And so if we're talking about clinical studies, we have a study with Yamab Ekbari in a neuro ICU where we're trying to look at applying it onto the carotid, but we have to be very sensitive there so that we don't collapse the carotid artery, especially in patients who have some stenosis there. And so we can actually this is basically applanation tonometry without having to really apply pressure. So this opens the door for us to do a lot of different things. And so I know I'm running out of time here. So I want to talk just a little bit about some of the clinical studies that we have going on. So using these sensors, we have a stroke study with Mark Fisher in his clinic, and we're looking at stroke patients versus control patients. We bring them in for about an hour and we just take their measurements, their blood pressure measurements continuously. And this is still a small study, but we have, what's interesting here is that all of these stroke patients have normal MoCA scores. And so they are cognitively not impaired, but they've all had a stroke. And compared to age-matched controls, this is an N=6 of each, we see a dramatic difference in both the systolic blood pressure variability beat to beat, as well as when you do a spectral analysis across the board, we see a dramatic difference in blood pressure variability for the stroke patients versus the age-matched controls. And this is aligned with what we're seeing in the literature with blood pressure variability going up with age as well as with disease. But even after you do a linear regression, you take out the age component with disease, with impaired vascular elasticity, we're seeing this variability, this increased variability in systolic blood pressure. In terms of understanding pain, we're starting to do some studies with our initial tests to understand pain. And so this is curious, and I don't know why this is. And so I just want to throw this out there in case anybody might have some ideas on what's going on. This is a subject with severe migraine episodes. When she went in, it was she had a pain score of about 4 to 6. We've tried measuring this with an Watch with a collaboration with Amir Rahmani, but we could not get any good readings off the Empatico Watch so far. So what we did in this case was we took the pressure sensor that we developed in our lab, we put it under Dorsalis pedis, so you can see it right here. We also had a non-invasive FDA-approved device called the Caretaker, that is a PPG-based device that we have measuring on the finger to make sure that we are getting accurate measurements off of this. We have a cuff measurement, and we also have EKG leads. And so we measured the systolic and diastolic and mean arterial pressure beat to beat with both our sensor, which is the blue, and the red is the Caretaker, the FDA-approved device. What is curious about this is during a pain episode, this standard deviation of the systolic blood pressure as well as the diastolic blood pressure went way down, specifically the systolic blood pressure. During normal days where there is no pain, the standard deviation of the blood pressure is pretty consistent with what we're seeing with all the control non-diseased patients. But during an episode of a pain score between 4 and 6, we're seeing a huge reduction in the blood pressure variability, which is counter to anything that I have so far seen in the literature. So I don't know, this is still an N equals 1. So, but what is interesting is that if you look at the heart rate variability, the LF, the low frequency, high frequency ratio is consistent with what we're seeing in the literature during a pain event, where the LF-HF ratio goes up with pain versus without pain. And so what we're interested in, as Dr. Gupta was talking about, is in being able to quantify sickle cell pain and to see if we can detect a VOC event before it occurs. So be able to predict VOC events. And she reconnected me with a colleague at USC who recently published this paper that identified elevated risk for future pain crises in sickle cell disease using PPG patterns. And so they looked at PPG signals while patients were sleeping, and they looked at the RR interval, so the heart rate and changes in heart rate, as well as PPG signals. And what they discovered was that they can, based on the magnitude, the mean of the PPG signal, they can actually predict the frequency of VOC events. And so we've been talking with them. I'm actually going to be presenting to CHLA next week to talk about this integrative sensor that we are developing with Bernard Choi. So this is an optical hemorrhage sensor that combines with our blood pressure sensor. We just got notified about 2 weeks ago that we came in second place in the NIH NIBIB NTAC challenge to create a sensor for maternal monitoring, so we can monitor both anemia, slight changes in blood flow, as well as continuous B2B blood pressure. It's a wireless device. We put it into a sock form factor. And so the really cool thing about this optical sensor is that it's about 40 times as sensitive as a pulse ox, and it's not it's a very small form factor. We can put it on the wrist or on in a sock, but we can measure flow. We can measure changes in flow, as well as localized tissue oxygenation. And so we're also less sensitive, significantly less sensitive to effects from darker skin pigmentation than a PPG signal. And so with this, we think that this might be a really nice way to monitor and be able to predict VOC events in sickle cell patients. And that's what we're hoping to jumpstart this collaboration with Dr. Koo, thanks to Dr. Gupta. So I am going to end it there so that we have time for our discussion.
Thank you, Dr. Klein. Really outstanding work, and congratulations on the NIH NTAC Challenge Award. Wow, that's really impressive. For the attendees, please feel free to add questions in the Q&A, but I'll get started first with Dr. Klein. So, I think, first of all, sharing your personal story was so impactful, and I think your work is now going to really change how we treat or prevent, conditions that, again, when it comes to what you can't measure, it's hard to treat anything you can't measure, right? So how do you envision some of the clinical translation for these sensors going forward. And also, for a lot of wearables and sensors, we're talking about direct to consumer. And how do you envision maybe in 5-10 years, sort of the direct to consumer ways in which your sensors could be used?
Yeah, I mean, those are great questions. I would love to, jumpstart more collaborations. I think I'd love to get these sensors into the hands of the folks who can use them best. I think that, really understanding pain, like I didn't even talk about like the baroflex response, like what can we do in being able to measure both respiration continuously with blood pressure and combining these sensors to really look more holistically at the patient. And so I'm very interested in those types of studies. And so I don't, I'm learning about all of this. So I really appreciate you and Dr. Gupta mentoring me, but I'd love to talk with clinicians because then I can find important applications for these sensors. I think in terms of their use, in 5 years, I would love to make these so easy and so foolproof that anybody can put them on and get accurate measurements. The problem with, I think, direct to consumer wearables is, if is a lot of times that you don't get accurate data from them. And so I think a lot of people feel like, oh, it's not very accurate. And so we're trying to do all of this. We're trying to do, FDA regulatory approval for all of these devices to show that we're benchmarking against the gold standards, that they are accurate and the limitations of where they are accurate, like in what settings are they accurate. And then, then we can trust the data coming from this, because at the end of the day, like the sensors are meaningless. What I really care about is the data and what this can actually inform us in terms of health and disease. And so, I'm really device agnostic. I want to get these sensors to a point where we can roll them out so that we can start getting them into the hands of as many people as possible. So we can start looking at the data and combining different data streams.
No, thank you for this careful work that I think, is part of that regulatory pathway to get data that we can trust. One quick point or question about your migraine pain study, with the blood pressure variability being less during pain. Did you look at the interaction with actual blood pressure value? Because, in a lot of people, pain causes an increase in just the actual blood pressure measurement. And I'm wondering if there's any interaction, just like we see with elevated heart rate and, decrease in heart rate variability.
Yeah, it was about 10 millimeters of mercury. So the patient has relatively low blood pressure. It was like 110 on the pain day and 100 on the non-pain day. So it was actually a little bit higher with the pain. But in terms of, the values weren't abnormally high or abnormally low. So it's a good question though. We did look at that because we're wondering if that affected the variability. And we also, I didn't trust the data. So we analyzed it a whole bunch of different ways to see if this was true. So we did coefficient of variance. We looked at all these different things to try to extract out the mean of the absolute values. And we're still seeing this effect. So I would love to talk with somebody if they have any ideas on what this is. That's
great. And then I think Dr. Gupta had a question. Can these sensors be linked to cell phone and apps?
Yeah. So right now it's a Bluetooth to a cell phone app.
Great. And Dr. Gupta, I have a question about your holistic approach to therapies in sickle cell pain. And you've had history of also understanding sort of the opioid mechanisms. So when you compare integrative mechanisms and integrative therapies to opioid therapies or pharmacological therapies, what are the differences specifically when it comes to sort of the disease modifying mechanisms versus analgesia and then effect size? And do you have to combine, like you have in your work so carefully, different integrative therapies to get the same effect size? I know that's like a multi-part question.
It's a very important question, Dr. Malik. You really hit the spot. And this is very important to remember, that nothing is one size fits all. And we have to take care of the disease. And can we find a common ground where we can do both, have a disease modifying effect and an analgesic effect or preventive effect. Now, your question, if I'm right, is can either or both integrative approaches and opioids, how do they modify how do they have the disease modifying effect, and how do they, or can they be combined to have a override some of the adverse disease modifying effect and provide a beneficial effect to pain? Am I right?
Yes, that's correct.
Yeah. So in that case, opioids have a good and a bad for sickle cell disease and for cancer. So they act via a signaling pathway, which is MAPK, ERK, and P38 MAPK. Both of them are implicated in tumor progression. So on one side, our lab is studying, doing a clinical translation that in lung cancer patients with NIH-supported work. The trial has just been completed, that if they have an adverse effect on tumor progression. Now, because that is due to promotion of angiogenesis, if opioids are used in, say, sickle cell disease, because sickle cell disease patients get leg ulcers, so they can have a healing effect. And we have shown that in mouse models, that opioids applied topically can have a healing effect. So what we can do is we can dissect out the mechanisms and then use them in a user-friendly way where we will have the beneficial effect and can actually reduce the harmful effect. At the same time, opioids, because they have a MAPK, ERK signaling and PDGFR beta co-activation and VEGFR co-activation, which was shown by my lab and then subsequently by many labs, that they can actually promote mesangial cell proliferation and kidney disease. So they can promote kidney disease. So in sickle cell disease, ESRD, and stage renal disease is responsible for about 40% deaths in adults. And we can prevent that by using less opioids or by using a combination of a COX-2 inhibitor, because they also act via the COX-2 pathway. And when we combine the COX-2 inhibitor at a suboptimal dose and the opioid at a suboptimal dose, they did not promote cancer. They did not promote kidney disease, but they still ameliorated pain because they activate COX-2 and mast cell activation. So on one hand, they act as an analgesic by targeting the nervous system. On the other, they act as pro-nociceptive or pain producing by targeting these entities which promote pain. And then if we integrate them with integrative approaches, like if we do acupuncture, we saw, and we do a smaller amount of opioid, we gave half the amount, which was suboptimal, which did not promote analgesia. When we gave that to mice that were resistant to acupuncture, actually, and then we gave them acupuncture and opioid at a suboptimal dose, they showed a very good analgesic response. So, and we also found that in these mice which have a genetic condition, there's a lot of heterogeneity, just like human beings from person to person. And not all the mice responded equally to acupuncture. But we found then the markers of central nervous system activation, inhibition that were responsible for this effect of acupuncture, whether it's highly responsive, moderately, or non-responsive. And when we tried to co-treat these groups on these mechanism-based targeting with either opioids in addition at a suboptimal dose, or with, say, substance P targeting with NK1 receptor antagonists, which are not effective in pain, but were developed, but have been used for nausea and vomiting in cancer patients, we could reduce the pain. So the good thing is, this is a very important question you raised. We always think of one size fits all, right? We think, okay, acupuncture can relieve it all. Opioids can relieve all the pain, but that doesn't happen. And so combining these we can override the adverse effect of one and promote the beneficial effect of the other.
That is fantastic. Yeah, thank you for sharing that work. We are running over time and have time for one last question. And the question is, are there different approaches necessary for those with and without comorbid mental illness? And Dr. Gupta, I'll start with you. You mentioned depression and looking at that as a variable?
I think it's a very, very important question. And in the present context of our society, it's one of the most. And I think absolutely we have to try this whole loneliness and depression, they go hand in hand, and mental illness. And how can we actually improve their environment by promoting them, whatever is deficit in their environment. So the first thing is something that I have coined is envirosome. And envirosome is not a single entity. If somebody is not sleeping enough, like Michelle, Dr. Khine has shown in her studies, looking at the sleep patterns, they tell us whether there will be vasoconstriction, where there will be pain. So they are involved in it. And I think envirosome, we also did, one of my collaborators actually, now she's at UCI, she looked at different zip codes in the LA area, and they were associated with poorer outcomes in sickle cell disease. So which means that the resource limited settings, the conditions we are living in, if the lights are on all night and we are not able to sleep properly, or you're not getting nutrition. So we have to look at this whole envirosome and take out and determine what is in this envirosome that is lacking in these people with mental illness. And then go with that. Does that answer your question, Dr. Pressman?
No, thank you, Dr. Gupta. That's excellent. I think looking at the envirosome, looking at comprehensively all the cofactors is what really will lead us down the path to treating something as difficult as pain, because of all the inputs that we've discussed, and getting a true biosignature of pain with innovations like Dr. Khine's sensors, and being able to quantitatively measure it will go a long way in helping us ameliorate all this suffering. So I want to thank you, Dr. Gupta and Dr. Khine, for kicking off our research speaker series. I couldn't have asked for two more outstanding, renowned speakers, and we're just very lucky to have you at UCI contributing to this growing knowledge and evidence body. So thank you.
Thank you, Dr. Malik, and thanks to Susan Samueli School. I forgot to mention that earlier.
Thank you.